see that you guys are here. I would recommend any family members or friends of people in recovery from opioid use should have Narcan available. We are not trying to predict relapses, but I would rather someone be safe rather than sorry. And just having that available, knowing that you could save somebody's life in the moment, is a certain level of reassurance and honestly a certain level of responsibility. So I would recommend having it, yeah.
I agree. Really, I recommend everyone have Narcan. I think that this opioid overdose and opioid use has been named an epidemic, and we all could potentially witness an overdose, and so it's better safe than sorry for sure. All right. Well, on that note, oh no, now we have more questions about that.
Dan with the follow-up. Jenny, do you want to address that one?
Sure. So some states do have different requirements. There is really no overall requirement to be qualified to use. The laws vary in different states per Good Samaritan laws and how Narcan can be accessed as far as through a pharmacy and whether the state has a statewide standing order to access. But as long as it's used in good faith, even our United States Surgeon General recommends that everyone carry Narcan and be familiar with how to use it. So if it's used in good faith, and as Colton will explain as we go through the presentation, it really is a very safe medication that has a specific purpose. And so they're usually, I have not ever heard of any repercussions if somebody uses Narcan and maybe the state has different laws or reasons. So as long as it's used in good faith and used appropriately, there should be no issue. Okay, so before we get too deep here, oh, we have more questions. Okay, so I am going to actually ask that everyone just hold your questions for a second. Colton has a great presentation that we have lined out that will go through many of the laws and much of the information and talk about kind of all of these aspects of overdose and risks of overdose and what to look for and how to respond. So please keep your questions coming. We will make sure we're scrolling through them. If we don't answer them as part of the presentation, we will address them as we're going and take some breaks. So I want to make sure we have a chance to welcome everybody. Welcome to this webinar. Thank you for attending on this Wednesday evening with us. My name is Jenny Armbruster. I am the Deputy Executive Director at NCADA. We are thrilled to be able to provide this opportunity. We are not as thrilled that we're not able to do it in person as the world has gone virtual, but hey, we can make this work, and we've made it work already in some other communities, and so we're excited to do it, particularly within Jefferson County, and we know that because it's virtual, we can have people from anywhere joining us, so welcome from wherever you are. I do want to give thanks to this opportunity being funded through the Jefferson County Community Mental Health Board. This is a organization within Jefferson County that provides some services and funding to the local Jefferson County community. So NCADA is lucky to have their support to be able to provide not only this training, but then following up some no-cost rescue kits available to all of you who have attended the training. And another special thanks to the Jefferson County Health Department. The Health Department originally was going to be our on-site location for these trainings and has since agreed as well to also be our distribution site. So at the conclusion of the presentation, there will be information about a short survey that I'll ask you to fill out. It's very quick, and it will be via SurveyMonkey. So if you have an opportunity to do that, it's just a few questions and then information on how to access rescue kits after you feel ready and prepared to respond to an overdose. So tonight we have Colton Baker. He is a certified peer specialist working with people in the recovery community, people accessing treatment. He is contracted with NCADA to provide presentations and work, and a good partner and friend of NCADA. He is knowledgeable and experienced in this topic. Colton is also works with the ARCHway Institute. The ARCHway Institute is another partner agency that provides resources for families and parents and individuals who are struggling with substance use and substance use disorder and looking for recovery services. And Colton is also part of the ComTree staff as the lead recovery coach in the EPIC project, which again helps people that have experienced overdose seek treatment services and recovery services. So, you know, Colton's resume is lengthy, and I gave you a snapshot of it there, and we're lucky to have him, like I said, with his kind of reach into the community, into many different aspects, and the many hats he wears. And I am going to stop sharing my screen now so that Colton can share his and get into the presentation. But as I said, I will be monitoring the chat box and the question and answer function to kind of help Colton along, so he can do more talking and less reading. And then stay on at the end, just the last few minutes before we wrap up. I'll have information about a short survey I'll ask you to participate in, and also how you can access Narcan starting tomorrow morning. So I'm stopping my share, and Colton will let him get on his share now.
Says host disabled, participant screen share.
Well, I don't think I did that. Let me. Sorry about that. See, technology.
No,
there you go. Is that working for you yet?
Yep. All right, thank you for the introduction, Jenny. Let's go ahead and jump into this. So this presentation through the MOHO project, you know, the objective here is to reduce opioid overdose deaths in Missouri through expanded access to naloxone, which is the medication name, Narcan is the brand name, through overdose education, through prevention programs, public awareness, assessments, referrals to treatment services for those people at risk of experiencing or witnessing an overdose event. Today, we're talking about opioid use disorder, what is naloxone, opioid overdose in general, how to identify one, along with the field report. So jumping in here, if you guys take a look at this graph, it kind of shows opioid use throughout time, starting in '99. The end of this graph goes to 2017. And you'll see a steady rise, but what I want to highlight here is the light blue line that you see skyrocket starting around 2013, 2014. This is addressing synthetic opioids other than methadone. I mean, this line is really comprised almost exclusively of illicit fentanyl. And so what we've seen here is almost a shift in what's been available in the black market for opioids and a dramatic rise in fentanyl availability, and as a result, fentanyl-related overdose events. If you look here, you'll see a graph representing opioid overdose deaths in the St. Louis region. You're seeing a steady climb here. The EPIC Outreach Project works with individuals who have experienced overdose and plugs them into treatment services. If you'll see around 2016, 2017, you start getting in the 700 range. If you look at, if this graph were to extend further, 2018, 2019, you're looking at over 1,000. So when you look at this in the St. Louis region alone, I mean, we're talking about a serious number of individuals that are, you know, dying of overdose, and that's not even addressing the individuals who lived, right? People who had an overdose event and made it through. And I would hope that this graph kind of highlights the importance of having Narcan available and having Narcan in the hands of the people that need it so that we can prevent this in the future. Here we kind of see a graph talking about, you know, in 2017, the St. Louis region accounted for 47% of statewide overdose deaths, which is a significant percentage, right? If you look at 2017, 84% of opioid-involved deaths in St. Louis involved fentanyl, right? And the graph on the right side of the screen kind of represents that, right? So you'll actually see a decline in heroin-involved deaths from 2015 to 2017, but you see an equally dramatic rise in fentanyl-related overdose deaths. And I'll get into that a little bit more in some of our further slides, but I would hope that this is highlighting the serious nature that, you know, fentanyl is causing fatal overdoses. I mean, along with not fatal overdoses, but it's a serious problem. And this is why, right? So you look here, these represent what would be a fatal dose: heroin, fentanyl, carfentanil. And this picture is here to represent, you know, what fraction of amount it would take for an individual to overdose on fentanyl, much less carfentanil, right? And this is why you're seeing such a spike in fentanyl-related overdose deaths, right? Keep in mind, when a person's buying illicit opioids, a lot of times you're seeing fentanyl mixed with heroin, but this isn't regulated, right? So every capsule that you get could have a different percentage of heroin, a different percentage of fentanyl, and the unpredictability there, the unreliability of the source, is leading a lot of individuals into an overdosing state just because they don't know what they're getting and they don't know how much of it they're getting. So if you look here, we have two pictures, right? One picture is heroin seized by the St. Louis Police Department. The other picture is an over-the-counter supplement. Typically, if we were in person here, I would ask you guys to raise your hands to guess which one's which, and then I would ask the follow-up question like, how sure are you? How sure are you that you got this question right, right? And so this would hopefully highlight caregivers of people who have OUD, that something that looks inconspicuous, that's in a supplement bottle or you just find lying around that you might think's nothing, could really and truly be, you know, capsules of heroin or fentanyl. And to tell you the truth, Jenny, you actually answered this question in one of our last presentations, but I don't even remember which picture's which, right? And I would hope that that would highlight the point behind this one to kind of draw attention to what you might be seeing if you're a caregiver of someone with OUD. Okay, so the United States has 5% of the world's population, right? We also consume 80% of the world's opioid painkillers, right? To put this in perspective, there are enough prescription opioid painkillers in the United States today that every man, woman, and child could be on opioids 24 hours a day for a month. All right, you look at roughly what, 330 million Americans, you do the math on that. We're talking about a huge supply of prescription opiates in the United States. Okay, there we go. All right, so 2/3 of heroin or fentanyl users, 67%, misuse prescription painkillers first. All right, about 2 years ago, this slide said 80%. Typically, you see a statistic go down, it's a good thing, but the net number of users has actually increased, right? And so this is highlighting a trend that more and more individuals are being introduced to heroin or fentanyl initially, not even starting with prescription painkiller misuse, right? And so I think there's a lot of reasons for that: availability for one, price for another. But I'm going to get into that a little bit more in upcoming slides as well. So addiction as a brain disease, all right? When you look at this, you are looking, sometimes this ends up being, people view this as a controversial topic, but I'm telling you, the greatest scientific minds have come together, and there is a mass consensus that addiction, substance use is a brain disease, okay? And you're looking at the progression of how this brain disease operates, right? So if you're looking at the bottom here, you're looking at symptoms, right? What criteria would you be looking for that? You know, using more than intended, impacting relationships, impacting employment, continuing to use despite negative consequences, right? Developing a tolerance is a big one. Experiencing withdrawal symptoms is a big one. And if you look at the progression of that disease, it follows a predictable pattern, right? The criteria is consistent over time, and the prognosis really is death or recovery, right? It's treatable. Addiction is a treatable brain disease, but it's not curable, right? It takes consistency, effort, recovery, but it is treatable. Look, OUD addiction is equal opportunity, right? So it really truly is important to avoid stereotyping individuals who are using opioids or using other substances. You know, substance use disorders do not play favorites. Can happen to anybody, right? Cuts across all boundaries, socioeconomic, race, age, profession, it really doesn't matter. You know, I use my experience on the Epic Outreach Project to highlight this sometimes. You know, I outreach individuals who are homeless in the city of St. Louis. I've also outreached Division I athletes. I've outreached lawyers. You know, I've intervened with doctors who have had problems, law enforcement. You know, it really truly is equal opportunity and can affect any individual. And so remembering that, keeping that in mind, especially when it comes to, you know, family members, friends, it really doesn't matter. Having that eye out and being aware of some of the signs and symptoms of substance use, along with resources that are available, is critical. You look at risk factors for substance use disorders, right? You look at victims of abuse, easy availability, poor self-concept, difficult coping with stress, weak family relationships, early experimentation, behavior problems, genetics. Typically during this slide, I would ask you guys, you know, what do you think is the #1 predictor for substance use disorder? A lot of times guesses I get are, you know, victims of abuse, easy availability, but the answer is early experimentation, right? When individuals experiment with substances at an early age, it can affect that individual's brain faster, and it can have a more damaging effect, right? So if you're looking for #1 predictors of risk factors for substance use disorders, it's early experimentation, right? And I think that's where, you know, NCADA has shined in a lot of ways with their prevention program in schools, teaching individuals about substance use, about healthy relationships, about how to avoid this situation going further, right? So why does it feel good? Why does using substances feel good, right? We're talking about dopamine release. Dopamine is the feel-good chemical that is released in your brain when you use substances, but it's not just related to substance use, right? Like dopamine is the motivator for human behavior, right? So if you look at, think of your favorite food, you want it really bad, you're hungry, you get it, you have about 150% increase in dopamine production, okay? Sex, feels good, you get like a 200% increase in dopamine production. Basically, 2 things that the human species needs to survive: food, sex. It feels good, you want to do it again. It's because of a dopamine release in your brain, all right? Nicotine, you're looking at like a 210% increase. Cocaine, roughly a 300% increase. And then you get to heroin. You're looking at a 2,200% increase in dopamine production in that person's brain, right? This is a tsunami of dopamine flooding this individual's brain, right? And so what happens? Your brain does not know how to accept all of this dopamine, and it adjusts over time, right? So an individual who's getting this huge wave of dopamine production from an artificial source, their brain adjusts. And what happens is they stop producing dopamine naturally, right? So it's like your brain's getting a paycheck every day without having to go to work, right? And so there's nothing else on the planet that can create this dramatic of an increase in dopamine production. There's nothing, you know, and that's a lot of times what keeps people hooked and keeps people using, you know. So why do people use opioids? Why do people continue to use opioids despite negative consequences, right? If you start at the left end of this graph, you, me, whoever basically operates in this white strip in the center. Okay, that's a normal baseline for human beings to be at. So starting on the left end, when an individual uses opioids, they get a huge increase in dopamine production. It feels good. You want to do it again. And over time, you see the line go up and down. That's an individual continuing to use opioids. They're continuing to get a euphoric effect. Feels good. But what happens over time is you start to get to the right side of this graph, a person's baseline ends up becoming a withdrawing state, right? And the reason is their body is developing a tolerance to opioids and their brain is not producing dopamine naturally. So their baseline becomes a withdrawing state, right? So now when this person's using opioids, they're just getting to everyone else's baseline, to everyone else's normal, that white strip in the middle. And, you know, people have this image of somebody using opioids and them nodding out. That's not always what it looks like, guys. You know, you see this, and a lot of people in long-term opioid use are using just to feel normal, are using just to function in everyday life. Look, I'm a person in recovery from OUD, and I can tell you that this is true. I can tell you that I've lived it, you know, and a lot of people stay in active addiction just because they're trying to feel normal. They're trying to stay out of a withdrawing state. Okay, talking about risk factors for overdose, right? If you look at chronic risk factors here, you're looking at previous overdoses, you know, a history of substance use, previous suicide attempts, access to prescription drugs, witnessing a family member overdose, or, you know, being prescribed high opioid doses or extended release opioids. What I really want to focus on this slide, though, is acute risk factors. So like right now risk factors. You're looking at a period of abstinence, okay, which is basically their tolerance goes down. Again, if we were in person, I would ask for a little bit of feedback here, but I would typically ask, you know, how long do you think it takes for a person's opioid tolerance to go to zero? Most of the time when I ask that question, I get guesses of, you know, a week, 2 weeks, a month. But the answer to this question is 72 hours. Even when I was in active addiction, I didn't know a person's tolerance went to zero in 72 hours, right? So think about all the ways a person might not use opioids for 3 days. You know, they go to jail for a couple days, they go to detox to try to get into recovery, they run out of money, they go out of town, and what happens is somebody goes 2, 3, 4 days without using or longer, and they're super high risk for overdose, especially, you know, if they try to use the same amount they were using before. So this is part of where overdose education comes into play. Talking to people you're caring for or your clientele or whatever, but understanding tolerance, understanding periods of abstinence is critical information for individuals with OUD to have so that if they do use, they can try to use responsibly. You look at a change of amount in purity. We're watching this happen right now, right? Basically, the way these previous slides have suggested, fentanyl is essentially taking over the black market for illicit opioids, right? I use a lot of examples for this, but basically, you know, you have a stronger, cheaper product, and people who traffic and sell narcotics are business people too, right? So if they can obtain a cheaper product that's more potent, you know, the math just makes sense on that. But the ramifications of that on a community level are you're seeing huge rises in opioid overdoses and overdose deaths, right? And so education around purity, around understanding that, you know, every single capsule that you might get, even if it's from the same person, could have differing amounts of heroin and fentanyl, pure fentanyl. It doesn't really matter, but the point is understanding that changes of amount and purity can drastically impact a person's safety. You know, using IV, straight to the bloodstream, pretty straightforward, higher risk for overdose. You know, mixing opioids with other substances. A lot of times I talk about utilizing when people use opioids and benzodiazepines, Xanax, Klonopin, Valium. I'm telling you, this is a very popular combination on the street because it gets you higher. They complement each other. But that's also the problem. When you mix opioids with other central nervous system depressants, you know, you end up in a much higher risk for overdose. Using alone. We always tell individuals never use alone. If you use alone, nobody can call 911. Nobody can administer Narcan. Nobody can help you. So never use alone. I don't know how many times I can say that in a row. Never use alone. Being physically ill or having respiratory problems. Just to be super straightforward and clear, individuals die from opioid overdoses because they stop breathing. Their heart works fine. They stop breathing. It is a respiratory depressant, so somebody with pre-existing or acute respiratory problems ends up at a higher risk for overdose. And, you know, homelessness within the past 90 days is an acute risk factor. So we look at opioid overdose signs and symptoms, right?
Colton, I'm sorry, we have a couple questions in the Q&A, so I'm going to jump in with those. The first is that this individual works with very young foster kids and has noticed that many of these children are given strong doses of psychotropic medications. Does this set them up for looking at drugs to fix their problems?
You know, I think that giving young individuals access to mental health treatment and mental health care a lot of times puts them, you know, in a better position to be able to cope with life in a healthy fashion, right? It's when individuals feel isolated, feel like nobody understands what they're going through, you know, don't have access to the care that they need, that a lot of times they end up turning to substances to cope with daily life or whatever mental health situation might be present at the time. So I think giving young people access to mental health care is actually quite the opposite. It puts them in a healthy position, a healthy state of mind to be able to, you know, cope with whatever mental health situation is present at the time.
Great. Another question we have is, how long does a person have to be using in order to create that chronic physical dependence?
You know, it depends on what substances they're using. It depends upon their route of administration. But I can say if you're using opioids consistently over time, it is inevitable that you will develop a physical tolerance. It doesn't matter if it's prescribed by a physician. It doesn't matter what opioid it is, illicit or legal. You know, if you use over time, an individual is going to develop a tolerance. And that's where, I don't think this slide's in this presentation anymore, but I think that's where you talk about working with physicians and properly educating patients who are being prescribed opioids, what physical dependence looks like, what responsibly taking their medication looks like, and creating an open dialogue with any prescriber as far as, you know, what are the long-term effects of you using this medication.
Excellent. Thanks, Colton.
Yeah. Okay, so overdose signs and symptoms. You know, if a person has one of these present, it might not be an opioid overdose, but when you start combining these signs and symptoms together, I mean, you're such a high likelihood that a person's experiencing an overdose. So what does this look like, right? If you start on the left side, you look at breathing will be slow or absent, right? Opioids are a respiratory depressant. Individuals overdose and die because they stop breathing, right? So what follows along with that, right? You start looking at, lips or fingertips start to turn like purple or blue from lack of oxygen, cold, clammy skin from lack of oxygen, not moving, can't be woken up. So like not moving, not responsive to stimuli, right? So if you're, trying to wake somebody up, whether you're slapping them, a lot of times I have a buddy who's an EMT and a firefighter, they'll do sternum rubs, right? I can tell you that if you're capable of responding, you will respond to a sternum rub. It's painful, right? One of the typical like dead giveaways of an opioid overdose is pupils are pinpointed. They're very, very small pupils. So the black center of your eye becomes very small. Something I try to reiterate during this slide is that, you talk about the choking or snoring sound that individuals sometimes produce as a result of an overdose. I have, some very sad stories of, an individual checks on little Johnny, and he's in bed and he's snoring, so they think he's okay. Wake up the next morning, little Johnny's gone. So even if opioid use, even if an overdose doesn't stop breathing completely, you want to look at, or you want to try to count how many breaths per minute a person's getting, right? Because an individual can still overdose and die if they're getting, 1 to 3 breaths a minute. So, we go over this slide, we talk about this stuff, but I want you guys to try to, imprint this on your mind, because it's one thing when we're on a Zoom call and it's a sunny day out and everything's going okay, but when somebody you care about or somebody is experiencing some of these symptoms, it's a high stress situation, and you have a mental and physical response to that. So knowing this stuff, having it in the back of your mind, this information is critical. It's critical for you to be able to pass it on to others who need this information, but understanding these signs and symptoms really and truly can save lives. Bottom line, right? If a person's unresponsive, if they have ineffective or absent breathing and pinpointed pupils, they're having an overdose. All right, this is a very close-up picture of a pinpointed pupil, but that's what it would look like. Keep it simple. I've done, OEND presentations for a lot of places, and I've had individuals who, have responded to overdoses and said, well, they had some of the symptoms, but some of them weren't. We didn't know, and we didn't know if we should call 911. We didn't know if we should administer Narcan. And like, look, guys, I'm just going to jump on this right now. If somebody is exhibiting these signs and symptoms on this slide, or multiple signs and symptoms from the previous slide, it is highly likely that person's experiencing an overdose, right? Another critical piece of information. The only thing Narcan does in a person's body is remove opioids from opioid receptors. So let's give a hypothetical that a person's in a diabetic coma and they're not responsive. If you administered Narcan to that person, they would have no negative side effects to any other presenting medical condition. Okay, so I would rather you be safe, keep it simple. If somebody's experiencing these symptoms, administer Narcan and call 911. So what is naloxone? Narcan, right? What I was talking about previously, this is hopefully a visualization of that, right? If you're looking at a person's brain, these blue points on here are opioid receptors. The orange dots here represent opioids, right? So when a person uses, opioids fill opioid receptors. That's what releases dopamine. That's what makes a person feel good. When you administer Narcan, what that does is it removes the opioids off the receptors and replaces it with Narcan. Narcan can bind to receptors stronger than any opioid, including fentanyl, and it will replace those opioids. That's what brings somebody out of an overdosing state. We go to this slide. This is what the words on the previous slide were describing. Okay, so if you look at the top left, you're looking at an intramuscular injection, right? Top right, Narcan nasal spray. Center, auto injectors. Typically, what you will see in the community, what you will see at Country and most providers is the Narcan nasal spray in the top right. Single step, super easy to use, and readily available through NCADA and other organizations. So I'm gonna talk about how to use that.
Hold on 1 second. Can we do 2 more questions?
Yeah.
Awesome. So first one, which I think we might still get to, but we'll go ahead and throw it in here anyway. What are the chances of an overdose if a person would mix opioids and Suboxone, which is a medication that is used in treatment, and would Narcan still work if this was the case? So can a person experience an overdose if they use an opioid and Suboxone, and would Narcan still reverse the overdose?
So one of the things about buprenorphine is a medication name, Suboxone is a brand name. So Suboxone is utilized for multiple reasons, but one of the things that Suboxone does very well is buprenorphine attaches to opioid receptors in a stronger fashion than, let's say, like Percocet or heroin. So a person could still experience an overdose. Let's just go to the point. A person could still experience an overdose if they were utilizing Suboxone along with illicit opiates. However, it's less likely because if you're taking Suboxone appropriately, it will bind to those receptors in a stronger fashion than illicit opioids like heroin or fentanyl would.
Okay, and then actually a couple more questions now. So
Yeah.
you had mentioned the sternum rub, the technique your firefighter friend uses. Can you just maybe kind of tell a little more about that or show it, or I don't know if I'm tall enough.
Yeah, so, you know, if you sternum, knuckles, and just dig in there like as hard as you can. I, for this reason, had this guy do it to me, and he's 6'3" and has huge basketball player hands, but he did this to me and I was like, you have to stop. It's extremely painful. And so if you're trying to check somebody's ability for responsiveness, a sternum rub is a very quick way to find out if that person's viable and if they're capable of responding. I hope that was enough.
Yes, thank you. I'm going to combine, we had a couple other questions pop up. I'm going to combine them. I think this might be stuff that would be covered, but we'll throw it out now. Can you talk about the effectiveness of Narcan on fentanyl, and if there's a difference if it's a pure opioid like fentanyl versus heroin? Do we have less time to use? Do you need to use more? Those kind of questions. And then about the nasal spray. So we know an overdose happens when someone stops breathing. So does a nasal spray still work?
Okay, I'm gonna answer the last question first. So Narcan nasal spray is absorbed by the membranes in the nose. So even if a person's not breathing, Narcan nasal spray will be effective at reversing that overdose. The first question regarding fentanyl and utilizing multiple opioids, and if that, okay. A huge percentage of the time, one dose of nasal Narcan will reverse an overdose. Narcan will bind to opioid receptors stronger than any opioid present on planet Earth, including illicit powder fentanyl. So it doesn't matter if it's fentanyl, heroin, a mixture of both, Percocet, Narcan will reverse an overdose. Was that comprehensive enough, Jed? Did I miss anything in that?
I think the only other thing, yes, and I've heard this analogy used, and you can correct me if I'm using it wrong, but, when we're talking about a difference maybe between heroin and fentanyl, we might be talking about a difference of minutes versus seconds. And so that's why we promote that everyone have Narcan, because if someone is experiencing an overdose, you might have a couple minutes if it's a heroin overdose. You might only have seconds if it's a fentanyl overdose. So fentanyl is a more powerful opioid, but Narcan will still work and still works because it is absorbed through the membranes in the nose.
Yes.
Okay.
Thank you for adding that.
No problem.
All right. So these are the three typically most used or most seen types of Narcan, right? Single step nasal spray, super easy to use. I'm going to go through that coming up here shortly. The IM intramuscular injections are highly effective. I just think you see less of them typically because a lot of people are, afraid of needles, and or, it can take a little bit longer to administer than the ease of a single step nasal spray. The center one, the auto injectors, are actually really cool. I've seen these a few times. You pull off the top and it's like, you have just opened Narcan. Press device against skin. It walks you through it, right? The reason these are less popular or less seen is because they are very expensive. So typically the easiest to use and the most cost effective is typically the single step nasal spray. And that's why that's the one I'm gonna explain to you guys in a little bit. So Naloxone Laws in Missouri, hopefully this will answer a question from earlier today. But Naloxone Laws in Missouri, Narcan laws. First responders have it. First responders have administration immunity, which means they can administer it to, anyone that's experiencing an overdose. Very important coming up. It's available at any pharmacy without a prescription. You do not have to have a prescription to obtain Narcan from a pharmacy. Now, every pharmacy might not have it in stock all the time, but it is available without a prescription. Pharmacists have, criminal and civil immunity to provide it to anybody who asks for it. Third-party access, right to possess, means you can have it, in your car, in your purse, in your home. You're not going to get in trouble for having Narcan on you. Any person administering naloxone in good faith with reasonable care has criminal and civil immunity, along with immunity from any disciplinary action from a professional licensing board, right? So if you're a nurse, you're a social worker, you're a teacher, whatever, you can administer Narcan to anybody in the community in good faith with reasonable care without criminal, civil, or licensing board ramifications to that. Any person or organization that has a standing order can distribute, store, dispense naloxone as long as they're not collecting a fee for it. So this is a very important slide, right? So this is the Good Samaritan Law in Missouri. We just have a question come in, Jenny.
Yeah, the question was, if our supply of Narcan from the health department is exhausted, can any pharmacy give us doses? There is a statewide standing order, so a pharmacy should be able to access it. It doesn't mean that they're going to give it at no cost. It is available over the counter at a pharmacy. Usually it's through insurance, so you would have to pay a copay, or you can buy it out of pocket. So if you're looking for Narcan distribution, that's why there's agencies like NCADA and many others throughout the community that work to secure other funding sources to be able to provide no-cost Narcan as well to reduce any of those barriers. But if you're looking to access Narcan, yes, you can walk into any pharmacy as long as they have it stocked, which they should. They can provide it. You do not need a prescription.
Thank you. So the Good Samaritan Law, right? What it says is a person who in good faith seeks medical care for someone who's experiencing a drug or alcohol overdose, is not going to be arrested, charged, prosecuted, convicted, or have civil asset forfeiture as a result of seeking medical assistance for somebody having a drug or alcohol overdose. I'm just going to keep it very real with you guys. The Good Samaritan Law has saved countless lives, because before this was in effect, a lot of people were left in apartments, left in vacant buildings, rolled out of cars because people were afraid of being arrested for substance use. I mean, you have to keep in mind, any amount of possession of heroin, fentanyl, paraphernalia is a felony, right? And the mindset of some people in active addiction was, I'm not going to go to prison for you. So, you start talking about the Good Samaritan Law and being able to call for help for a person experiencing an overdose without fear of being arrested or prosecuted as a result of seeking that help is a critical is an understatement, is a critical law to being able to save people's life on a daily basis, right? What's not covered under the Good Samaritan Law? So outstanding felony warrants unrelated to that event, police can take you in for outstanding felony warrants. And the second bullet point is basically around sale or manufacture of illicit substances. So you can't be selling heroin, have someone overdose, and then not getting in trouble for, selling narcotics. That's just not going to happen. But I really just can't reiterate enough how critical the Good Samaritan Law is to saving lives. So, slide about what is Narcan. Please lock this information in wherever you can store it in your brain, because, Narcan is a medication that reverses overdose. We've talked about that. Onset of action officially is 2 to 3 minutes. I've seen it work, much faster than that. But this third bullet point is important, right? So the effects of Narcan start to wear off after 30 to 90 minutes. If you average that out, you're looking at about 60 minutes. Understand that, many times when a person overdoses, sometimes they've taken enough opiates to be in an overdosing state for 3 hours, 4 hours, 5 hours. So when you administer Narcan, it's possible for someone to slip back into an overdosing state. I've seen it happen, right? And so, it's important that a person, seeks medical attention, or at the very least that you stay with that person and monitor them throughout the duration of what that overdose could be, right? So if you administer Narcan to a person, very important that they don't use again. And it's also very important that you stay with them or seek medical help for them to make sure that they're observed and make sure that they do not fall back into an overdosing state. So what to do if somebody overdoses? First and foremost, boom, call 911, get medical help on the way, right? As soon as 911's dialed, administer a dose of Narcan. This is what Jenny mentioned earlier in this slide, minutes matter, seconds matter. So as soon as you find somebody that could be in an overdosing state, to do a fast assessment, call 911, administer Narcan as quickly as possible is very important. Administer rescue breaths once you administer that first dose. So, rescue breathing is quite simple. An interesting piece of information is that, you could actually keep an individual alive throughout the duration of an overdose just by rescue breathing for them. That would be an extremely arduous process to rescue breathe for someone for hours, but you could do it. Staying with the person and administering a second dose, 2 to 3 minutes after the first. This is one of those slides where I feel like I'm just saying words, but, understand that when you find yourself in this situation, your heart rate skyrockets, your adrenaline starts flowing quickly, and I don't want to say in a panic state. It's important not to panic, but you're having a physical and a mental response to this event. So having this information, knowing it like the back of your hand, really and truly can save the life of somebody who's overdosing. Airway tips, again, talking about rescue breathing. You want to tilt that person's chin up to make sure that their airway is not obstructed. Lift the tongue out of the way and administer rescue breaths. How to use Narcan. This is the easiest 3 slides in this PowerPoint, I can tell you that, because I would speculate that I could not tell any of you how to use single-step nasal Narcan, and you would probably know how to use it. So very easy, right? Open the package. Open the package of Narcan. Step 2, you'll see the nozzle. Put it in the person's nostril. Make sure it's in there. Step 2, press the plunger all the way down. It's 1 spray, done. You don't need to prime it. You don't need to do anything to this. Open it, put it in the person's nostril, press the plunger all the way down. That's what the spray looks like. Then we follow the rest of the follow-up steps as far as responding to that overdose. But very, very easy to use. As a follow-up to this presentation, if any of you guys have questions about IM Narcan, auto-injector Narcan, I'd be happy to help with that. For the purposes of time and of this presentation, we're going to go over single-step nasal Narcan. Understand that when you administer Narcan to someone, what happens is you pull the opioids off the opioid receptors. 50% of the time, no negative side effects, right? Person responds, they're awake, they're alert, they're not in an overdosing state anymore. But understand that, if you rip all of the opioids off of all of their receptors, there's a likelihood that they're going to get dope sick, withdrawal symptoms, right? So what are symptoms of withdrawal symptoms? You're looking at maybe anger, maybe a little bit of irritability, dope sickness, 7% of the time you might experience vomiting, but I've had, my friend who was a paramedic who has administered Narcan to individuals who were dead, and dying, and woke up and were like, why'd you do that? And, it's explaining like, listen, man, you were not breathing. You were going to die. I had to do it to save your life. I think the reason I tell that story is to understand, that even though a person might be frustrated or angry, irritable, have dope sick feelings, they'll understand that you did it to save their life. The bottom bullet point on this, combative, you're looking at 4% of the time. I would speculate that it's lower than that. There's certain, this rumor gets pervaded throughout the community that, a person might wake up and try to punch you in the face because you Narcan them. The statistical likelihood of every single person on this chat reversing an overdose is low. The statistical probability of that person being combative with you is far, far lower. And to tell you the truth, if I was Narcanning a UFC fighter and I knew 100% they were going to punch me in the face, I'd still do it. We're talking about saving a human being's life, right? And it's like, irregardless of the possible negative symptoms they might experience, I'm saving that person's life. So the rationale why project evaluation is important. Short answer is if you receive grant funding for something, you need to be able to show outcomes, right? So how can you track outcomes for Narcan reversals, right? You have to ask the people who are administering Narcan or who are experiencing the overdose, right? And so if you go to mohoproject.org/OD report, you will have an online app that you can fill out a field report on.
All of this information will be with the rescue kits if you choose to pick one up from this project. So don't worry about trying to write all this down real quick. You'll have easy to use info cards in those bags too.
Cool. Thank you for throwing that in. You know, initially when I present the field report to people, a lot of them will say, well, I don't want to fill that out because I don't want people to know that I overdosed or that my family member overdosed. There's no identifying information on this field report. The closest thing you get is a zip code. Okay, so you're not going to be putting anyone out if they experience an overdose, if it was a family member of yours, a friend of yours. There's no identifying information, but it's important for us to be able to collect this data to be able to continue to provide Narcan to the community that needs it. So please, if you find yourself in any of these situations, take 3 minutes and fill out the field report.